The other expert is from China Medical University Hospital, and Dr. Wang Chien-Chu. And I think many people already well known this young staff. Today, her talk is a better way to perform the adenomyomectomy. Actually, this is the biggest challenge for most of the gynecologists. Let's welcome Dr. Huang.
Okay, thank you, Professor Wang, for the kind introduction. Today's my topic is a better way to perform the adenomyomectomy. As we know that why we have so many classifications about adenomyosis, it means that there's not a good way to perform the treatments, and otherwise everybody try to find the good solutions to the adenomyosis. So in one of recent studies, they found that typically we can focus on the different types of adenomyosis, including the diffuse type, sclerotic, nodule, cystic, and most of the type is the diffuse one, and which cause the menorrhagia and most of the symptoms of the adenomyosis. And most patients with the diffuse type. But how to operate in the diffuse type? We know that it didn't have the obvious border, so how much is enough is an important issue. As we see that under the symptomatic of adenomyosis, if we actually regardless of the weapons, it not only have only the operation way, and first of all, the most important issue to our concept is whether the patient have the fertility desire or not. If she have the fertility desire, then the myometrium we need to preserve all the time to let her enter the IVF course is an important issue, because we know that both the adenomyosis and the age also the important issue for the fertility. Otherwise, if without fertility desire, we need to concern that whether we are going to perform the operation for symptomatic relief for other purpose, or we can try the medical treatment first. But as we know that the definite treatment of the adenomyosis actually is a hysterectomy. So we can see that actually before the operation choice, we can consider the medication treatment first. Then if medication treatment is bad, or still the patient got lots of the problems, we can conduct the adenomyomectomy or the hysterectomy. So we can see that actually there's two types of the operation method. One is called type 1, the other is type 2. It's based on whether you resection much of the tissues or you just resect partially. So, but we can see from this outcome that no matter it's type 1 or type 2, actually it's a personalized operation. You need to design before the operation because it can have good outcomes, but it really needs individualized management. So as we can see that adenomyosis really have the important impact on the infertility, and we see that not only the adenomyosis but also endometriosis. But we can see if really only the adenomyosis only still decrease the pregnancy rate quite much. So actually in the infertility part, we can see that if really the patient try to have the desired pregnancy, probably conservative adenomyomectomy is considered. And what about the concept of the adenomyomectomy? Actually, there are three important concepts. First, we need to prevent the deformation of the cavity. Another one is we need to preserve enough myometrium. The third one is that in case of the uterine rupture and the other complications, tension-free suture is an important issue. And also, before the operation, we need to evaluate the patient's uterus and the size, the age of the adenomyosis carefully. And after the operation, also the adjuvant medical treatment helps a lot. So we can see from those a lot of the trials, we can see that if it's really the adenomyosis in recent days, they found that not only just resection directly, because if we resection the adenomyosis directly, most of the time we are not unable to suture it. So in recent studies, most of the operators, they choose to preserve a flap, whether it's a double suture or a triple flap suture, preserve a flap over the outside part of the uterus and try to resection much of the inner part of the myometrium is nowadays the most common operation methods, and it really shows an important and good outcomes of the post-operative about the no matter the pregnancy or the symptomatic relief. And also we can see from this type also how to preserve the flap and closure the cavity first, then closure the dead space, then closure the outer layer. It's the core concept of most of the good outcome studies in recent days. And we can see that under this status, sometimes even still need IVF, the pregnancy outcome still really improved. And also, what about besides the laparoscopic method, what about the laparoscopic? Then we can see that we got lots of the useful tools can combine with the laparoscopic adenomyomectomy, including the pre-medications or the osteosis and sometimes the arterial occlusions. There are all the methods we can help under the laparoscopic adenomyomectomy. And also at the same time, even though it's sometimes hard, but they found that under these wedge resections, we can see that no matter the SCA-125 level, the uterus size and the symptoms also improve a lot under this kind of that we wait not only do the weight but also do much of the radical adenomyomectomies. And we can see that under these conditions, you resection first, then you incision inner side of the adenomyosis lesions, then closer it whether under the double flap or the triple flap. And what about the robotic adenomyomectomy? As we see that adenomyosis really causes a firm uterus surface and the inner part. So actually, under the scopic, suture is quite challenged. What about the robotic? In our concept, we also always think that robotic was more flexible on the suture part. However, in a randomized control trial, they compare in Korea, they compare with the laparoscopic and the robotic. They found that actually there was no obvious difference or the benefit compared with laparoscopic adenomyomectomies. As you can see, another most important issue is that what they choose on the robotic part was that most of the adenomyosis was more on the focal part. And the patient's actually fertility desire was much more less. So actually the robotic part, those patients was more, rather for the fertility desire, they are more to the symptomatic relief parts. So the next one, I'm going to demonstrate my mentor's William Zhoulin's video of the laparoscopic adenomyomectomy. Actually, this one was performed 10 years ago because nowadays we've got so many medications. So actually, my adenomyomectomy was no longer that often seen in the operation theaters. So we can see that due to the limitation of time, I fasted in 10 times. So we can see that the first important part is that you close the part near the cavity side with the firm suture of that part. And we can see that actually under the laparoscopic, sometimes it's hard for you, if you actually, even if you are tired and experienced in the suture, it's hard because that you can see that your system is hard to compress to achieve the tension free. Because we can see that when those firm tissues under the instruments, it's quite difficult to compress it closures. So it's a first layer suture, and the second layer suture we are going to conduct is to closure the dead space. So as we can see that no matter during the operation or before the operation, you need to have a really well-known plan and landscape inside your mind that how much you are going to resection. Because once if you really incision too much, then it's hard to closure the wound and closure the uterus inside the operations. So the second layer we need to achieve the most important concept is try to make the tissue tension free under the suture and also closure all the dead space. Okay, so we can see that after we closure the second layer and all the dead space, then we'll conduct it into the outer layer part. And at the same time, we can see that because adenomyosis got so many small vessels, so you can see that the oozing and the bleeding is also a big problem. So we'll mention it later that some of the tools we also can combine not only the pre-op operations, medication treatment to shrink the size and decrease the blood vessels. Just like these times, we can see that even the assistants try to compression, but actually it's hard that because adenomyosis sometimes both outer layer is firm, so it's really hard to achieve the tension free. Even if you compress, you traction it. So as we see in this video, you can see that sometimes probably we are not able to suture from the top up to the end. We could be segmentation it, separated into different parts and should closure it layer by layer. Okay, so the next. So we can see that from this video that previously it was this size. After we resection the inner part of those adenomyosis tissue, then we closure it in the firm way. So what about other things to decrease the bleeding? We can see that some of the operations try about the transient occluding the uterine artery. They found that it's quite effective, and some also try like the IV injection of the oxytocin pump during operation. What about we use the tourniquet? Actually, most of the time they use the tourniquet in the studies due to it was the large diffuse part size of the adenomyosis. But however, actually there's no obvious one study show that it can significantly decrease the blood loss during operation. So in some of the study they review, like just we mentioned, the different types of the adenomyosis. They found that actually about most of the diffuse part, after the patient finally go conduct the LTH, and about the sclerotical or the nodule part, actually laparoscopic incision is capable and able to approach. But what about, we need to mention to the patients that adenomyosis is definitely recurrent after the operation. And what about those risk factors, actually including the pre-OP to high level CA125? And they found that post-OP, with the post-OP medication, you really can decrease the recurrent rate. And also, operative do increase the pregnancy rate. So this is can inform the patients. We can see that the total birth rate can improve up to 37, and if at the IVF, you can increase to the 47%. And also, not only the IVFs, in lots of the studies, we still can see the spontaneous pregnancy still happens. But as we can see from those studies, actually, it needs quite much patience. So I think that the most important issue that you need to depend on patient's age. If really the patient is at advanced age, actually we can see those long times really is not suitable for the patients. So what about the most complication of adenomyomectomy is the uterine rupture. And in one Japanese study, they start to see the details of the uterine rupture after operation. They found that no matter you conduct a preserved, conservative, or radical adenomyomectomy, actually the key point of the uterine rupture was on the suture side of the myometrium and the uterine cavity. So actually, why suture is so important in this operation is this. And also they found that not only just easy rupture, at the same time they found most of those patients got a placenta increase problem. So you can see that also sometimes the scarring tissue really causes placenta to melt implantation and cause the complication of the uterine rupture. So back to all this concept, we can see that there are three core concepts of the adenomyomectomy. That is that we have the landscape in our mind that how much we should resection, and we perform the deformation of the cavity. So on pre-operative sonography to monitor the distance of the cavities and know where is the cavities in during the operation is an important issue. And then we try to preserve enough myomectomy. And then we try our best to create a tension-free suture. And at the last, we can see that it's also the most important part that whether the patient have the fertility desire or not, that we decide before after the medications whether they conduct a myomectomy or the hysterectomy or adenomyomectomy. But in our hospital's experience, our opinions, if the patient really want to have the fertility desire, actually, because after this operation, the patient still need to conduct the cesarean section. So probably we just try to conduct the opening method to the patients. And also, good doctors know when to operate, and great doctors know when not to operate. So we also need to know how much tools we have at the same time. Medications and the other like HIFU and all the other things. We need to inform the patients, and the patient and doctors decide at the same time. Okay, this is my speech. Thank you for your attention.